Part of your evening with us. No cheating tonight. I don't want anybody venturing off to check the World Series game. Just go ahead and record it. You get through the commercials that way. Are you a baseball fan at all, Guy?
No, not really.
The World Series is the only time I can even watch baseball. Like, I can't watch a baseball game, but I do like to watch the World Series. So, and I grew up in Southern California, so I'm kind of, even though I live in Texas now, I think I'm kind of pulling for the Dodgers. So.
Yeah, I'm just not the biggest baseball fan. My wife's the sports fan in the family anyway, but we watch some football and hockey, and baseball's pretty far down on the list, but I know it's big to some people, and it's fun to see in person. We like going to Rays games around here ever so often, and hope everyone's doing well. We appreciate you taking time away from that. We're going to start right on time here, which is right about now, I think, Rich. So I know some people are still logging on, but we try to be respectful of everyone's time. And thanks, Rich, for manning the ship last couple weeks ago without me. We had part one of this and stuck on a plane. And Rich, it sounds like you managed to get through it all by yourself. So, which makes sense that you've been doing this longer than I have. So thanks for your help on that one last week. And we're just going to carry on with part two of just some things that Rich and I have learned, and we've learned through some of you all out there about how we manage certain aspects of our dental sleep practice. Just some quick things that can really help you get over some of the hurdles. Next time, we'll be talking about one of the most important topics to a lot of people, and that's billing, and in particular Medicare. And I think, the reason Rich and I decided to do this is Rich and I were talking, and we hear people say, "Oh, I'm afraid of Medicare," and "Oh, do you really want to get involved in Medicare?" And Rich and I agree that, I love it when I see a Medicare patient come in because it's predictable. We know they have coverage. They're usually pretty good patients. They're usually retired and have time. Rich, aren't you in the same mindset?
Absolutely. And if they have a secondary insurance, sometimes we get them to pay quite a bit for it. So, yeah, we don't want you to be scared of that. The best thing about Medicare patients, Guy, I found is they can't really remember what happened last time. So if it wasn't good, it's not, no, that's not necessarily true. We have some very spunky, we have a 93-year-old lady we made a dental device for the other day, and she is, she's a little firecracker, man. She's full of energy, but yeah, don't get scared away from that. Let's figure out, let's just break it down. This is what Medicare requires. This is what the sleep study is. This is, all of those different things that are involved. It's really not that complicated. And that's what Guy and I really try to do. And what we try to do through Dental Sleep Solutions is simplify things so that we can break it down into its parts, and then we can manage it and implement it in our practice. Yeah,
so we'll teach you some of the more details than we've gone to in the past about being prepared for the visit and really some techniques to get paid really even better sometimes on Medicare patients. So that'll be next time. We'll mention that again here a little bit. Here we are, Meet the Doctors. And I thought it was Halloween, Rich, so that's actually me there. I think I did a pretty good job on my teeth there. Made those myself years ago in the dental office, but all right, I'll get that out there if I'm scaring anybody. That was my Halloween costume for later on in the week.
Who are you supposed to be?
Who knows? Just some big scary guy like I normally am, but this even scarier. But I was thinking
Alice Cooper. You looked a little bit like Alice Cooper. But,
Well, Rich and I have been friends for a long time. We've been doing this for over 30 years between us, probably closer to 35 now, I guess it has. We've done thousands of devices. Today is a really kind of unique webinar we're doing because we're going to share with you some of the techniques that we do for some specific situations. We, every day, help our patients with dental sleep, and that's what DS3 does. We're the most trusted, innovative, customer-focused provider of solutions in dental sleep medicine. That's our mission statement. We do this through our we call the 4 pillars, which is screening, testing, treating, and billing, and we provide support for those. And we do courses all over the country. We're winding down this year. We got one. I'm heading out to California on a Thursday, I guess I'm going out there, and then Dallas we have one, and then we're just about to get our first quarter calendar, first half of the year calendar finalized for next year, but we'll be adding quite a few more courses. If you want to come to one of these, just type in course, and we'll give you $100 off one of the courses coming up. Even if you don't see a date there that is in your schedule, you might want to type that in, and it'll save you some money in the future. And Jody or Brandy or someone will get in touch with you. The symposium, Rich, is getting more and more exciting for 2018, isn't it?
Yeah, was our inaugural event last year. We kicked it off in February of 17, and especially for you Easterners up there, what a better place to be than Florida in February, right, Guy? So we got a great room is that the Hilton?
Yeah, the Hilton on Clearwater Beach.
In Clearwater Beach. What a beautiful place. Take a couple extra days on the front end and the back end, and in between get some very practical things that you can implement in your practice. I'm going to be talking about marketing. Guy, what are you talking about? I don't even remember.
We're going to be talking about how you manage and create physician referrals. So we're going to go into detail on that. And everybody's talking is going to be talking about very practical things. And I want to mention we got a really good room rate too. I live here in Florida, and rooms anywhere near the beach are $400 plus a night. And I think we have right around $250 a night while they last for the rooms. So if you're interested in coming, it's a fantastic value. And it was one of the best few days I had last year as far as camaraderie and education. We all learned something. So again, we'll talk a little bit at the end, but this is what we do. We help our practices. We have a few dozen team members. All they do is get up every day, go to work, and they help offices to screen, test, treat, and bill their patients. And we do this through helping with education, not only like this, but more hands-on coaching with live go-to-meetings and in-person sessions when needed. We have the best dental sleep software out there, and we have support for our members. And a lot of members join these webinars as well. And if you talk to any of them, they're going to let you know that we certainly take a lot of the guesswork out of dental sleep. If you want to do this, we'll lower all those hurdles. If you're interested in knowing more about what we do, just type in consult if you want. And one of our team members will talk to you, find out where your challenges are, and see if we can help, and you'll get a lot of free information out of it. So just type that in anytime throughout the webinar. And if you have questions, type them in there, and we'll be answering those as we go. All right, so enough of the housekeeping. Does this ever happen to your patients, Rich? Maybe not that bad, huh?
Yeah, sometimes, when they say, how much does that little piece of plastic cost? And we say, well, but they let we have all kinds of things to that. What do you cost? What's your good sleep worth? What's your marriage worth? Right. I remember that good buddy of yours, Guy, that one time said, he lost $40 million, but the good news was he still had $40 million. But
yeah,
that was a bad day. But yeah, we talk to us, Guy. What do you got here?
Well, I think Rich is talking about the jaw opening from our fees, but hopefully if we manage insurance correctly on our next webinar, we'll teach you how to prevent that jaw opening. But today we're going to talk about, one of the challenges we have in dental sleep is the patient says, I'm still snoring. My wife's saying my mouth's open and I'm still snoring, and we advance the devices more. And as you advance the devices more, sometimes that'll help, but sometimes we're like we're not doing anything. And this vertical component, the fact that some of the devices allow opening, can affect the efficacy of the devices. And we love that the devices can open because it makes it more comfortable. Patients can swallow. You can talk to your spouse or maybe even answer the phone without taking one of these devices out. So especially for someone like me who can't breathe through their nose well, it makes it far less claustrophobic. But at the same time, if my mouth opens to a certain extent, it may negatively affect the efficacy of the device. So the number one thing we mention on any device that allows mouth opening, we want to also be able to somehow minimize that opening, whether it's a Herbst or a dorsal device or a Narval, as we're showing here.
Yeah, we don't have that problem as much with the Dream Tap, that hooks in the front. So that has its own set of issues. But, in general, we want to keep the jaw, if we think about, Guy, I always say, well, the jaw falls down and way back. That's not a good thing. But even with the device in, it can be opening and closing a little bit, but it's still not going back. We might want a little bit of extra force to keep that closed. So show us your trick for the Narval, Guy, which doesn't come with a little hooks on it like the the Herbst and the dorsals do to put rubber bands on.
Yeah, so what Rich is saying there, by all means, if you order devices that an option is to get the elastics, then even if they charge you a little bit more, which most labs do, I recommend getting the hooks or the elastics added to the dorsal or the herps, just so they're there in case you need them. But if you have a material that's really strong, like the Narval or some of the milled acrylics, some of the milled acrylics or the really densely, the ones that are waxed and then invested acrylics, then you don't have to have hooks, which is nice because they don't poke out at the patient's cheeks. So if you happen to have already made a Narval and the patient's mouth is dropping open, then you can just take a burr or a disc of sorts and just make some grooves to hook the elastics to it. Again, this will work with some harder acrylics, in particular, like if you have a Micro 2, yeah.
Keller Clear Dream.
Correct. Those you can just make these little groove spots and then just smooth them up. And if you're better at it than I am, you'll line them up straight. I didn't quite get that one perfectly straight there, but it really doesn't matter that much that they are straight. And then you can put it in the patient's mouth. Now we have an assortment. I don't know about you, Rich, but we have 3 or 4 different sizes as far as diameters, and we also have 3 or 4 different sizes of elastics just in our office, just in bins that are different rigidities, because depending on how far apart these grooves you make, or if you ordered them from the company and they have little hooks to hook them on, you might need different sizes. So having an assortment, just go ahead and order them and have them in your office is a good idea, because you don't know what size you need often at times until you try these in. One thing to mention on this too is your devices are going to have to fit tighter, right?
A little bit, certainly wherever you put those rubber bands. And the other thing too is the latex allergy. So you can get all the rubber bands non-latex, just in case that's an issue with the patient.
Very good. And we talked last time, I think, Rich, you covered how to make these a little bit tighter. So one thing I always check before I add elastics to any device is how tight is it? And if the device is really loose, it's staying in there because this patient allows opening, right? But the moment you put these elastics on, it may start popping it loose. So I might want to look and see if I can make it tighter prior to adding the elastics, because you'll add these elastics and then they come back in the next day saying, well, now this thing's popping out of my mouth. Every time I open, I'm finding it stuck to one arch or the other. So checking the retention on these, and this makes it a little less comfortable. So that's why we don't always just give people elastics 100% of the time, because sometimes the devices work quite well without the elastics, and if it does, then why make it less comfortable and cumbersome to the patient. But I will say this, that I think it's underutilized. The reason we put this in the pearls is not that you couldn't figure out how to put these little grooves in here if you needed to. But one of the common questions I have when I'm talking to dentists in our study club for our members that we have a little more intimate setting, they're like, I'm advancing this person, they're not getting anywhere, and they're wearing a Herbst, a Narval, a dorsal design, something that allows them to open, and we tell them, let's add some elastics and see, and it can go from night and day. It can go from this device snoring to AHI not being where we want to where everything's working real well. So don't underestimate adding elastics is the real bottom line on this. Does anything else on that, Rich, before we move on to the tap backing up?
No, I think you touched on some good things there. You do have to make sure it's tight enough, because you don't want to introduce something that you think is going to work and then it ends up backfiring on you. So, make sure before you even mention elastics that you do make sure it's tight enough. So let's talk about the Dream Tap now. So I'm a big tap guy. I learned a lot of stuff from Keith Thornton early on. So, whatever we learn initially, Guy, we kind of tend to hang on to, right? In some ways. And I've had to branch out over the last decade certainly doing other devices. And there's always new devices coming out. That's something that Guy and I try to stay on top of through Dental Sleep Solutions and these types of webinars. So, the Dream Tap now, I probably don't make it quite as much, Guy, just for that retention issue, from canine to canine on the top, because we moved the plate to the bottom and the fulcrum point is a little bit further. We talked about this last time. If you all missed the first one, by the way, you can go to the YouTube channel, Guy, I believe, and you can go ahead and view that at your own leisure. But we did talk about some of that stuff. But the issue with the screw sometimes is if you get somebody that's kind of big and strong, and if they're clinching a lot or they're doing something, that the screw that the hook sits on that moves forward and back like that, sometimes that thing can kind of jump those threads and it can start backing up. And they'll say, "Oh, it was working great, for the first couple of weeks, and now it doesn't work anymore." And how many turns are you at? Well, I'm at 14, and you look at it, they're at 0. So you got to pay attention to it.
Yeah, from the first time I had that happen, I thought, well, the patients they're not understanding or doing something wrong, and then it happened again, and then it happened again down the road. And so, I at first doubted that my patient was understanding or being truthful, and the truth of the matter is that screw somehow backs up. And so the more force that's been put on it, the more it can happen. It doesn't happen that often, but part of the pearls here is we're hoping that by exposing you to this and you're doing some of these devices, and I see some of the questions coming into, by the way, Rich, we'll get to all those before the night's over, that we can alert you to this as an issue that happens at times and what to do about it. And one of the things I used to do in my dental office when I had one of these micro lectures is I just took it, Rich, and I just, around that screw, I just sandblasted it with the micro etcher. And I think it just caused enough grit and resistance to keep that from either jumping those screws or from backing up. You can certainly do the last thing that you already said. You can call airway management and say, I want a new screw, and you can take this face plate off here with the wrench they provide and pull this off. And I think we even showed the last webinar how to do that, in particular, kind of some techniques for it. And you can replace that internal screw. And something that I found that works quite well is just taking some acrylic, but actually thermacryl works really well. If you just heat up some thermacryl, which is a material that we use quite often in dental sleep, it's just a heat sensitive acrylic, you just squish it back behind the screw. Well, it'd be in front on the dream tap, because it's the opposite, to keep it from going forward. On the old one, it'd keep it from going back. And just throw it in cold water, and that'll keep it from moving in the wrong direction. And then if you ever want to take that out, it's real easy. Just put it in some hot water and you can just dig it right back out. Do you have any other tricks other than that, Rich?
No, you can do the acrylic as well, but that's a little bit more permanent. It becomes very, very difficult to get that out. I didn't know about the micro etch, Guy. That's a good idea. I hadn't thought about doing that. So I always learn something from Guy every time we do these things. You've got to have, if you do one tap a month, you got to have a couple extra of these screws. Okay, you just do. I mean, they don't cost that much money. Just get a couple of them, and that way, you can just fix it in a heartbeat like that. You don't have to do that. So these other tricks we're talking about trying to do if you don't have the screw and you can't replace it.
Right. And I would also mention having several of the hooks. You talked about it last time. The hooks come in 3 sizes, having the screws and a few of those hooks around, because you don't want to wait till the patient comes in and go, oh, I've got to order this. They're not that expensive. So just if you're going to do this, have some of these things around. Also, adjunctive therapy. I mean, have things we're going to talk about here in your office. They're not that expensive. And adding things, doing things to help our patients to sleep on their sides, to help their nasal airway, can really make a big difference in our treatment effectiveness. And again, I see some questions coming in. We're getting to them as we go. But this is something I think you taught me about this. I didn't know about these until a few years ago. These nose cones. You use these. You have these in your office, right, Rich?
Yeah, we do. They come in a white and a clear. One of them is a little more rigid. They do actually come connected. We cut these things off. There is a connector that goes between those. So what we found is, you just in the middle of the night you reach up and rub your nose, or you do something like that. But basically, I think a really good test for this guy is the old fashioned. Let me see how well you breathe through your nose. Right? Plug up one side and breathe in, and when you do that, put your mouse right on the little edge of the nose there, the A-leg, the little crease there. I don't even know what you call that. behind the nose opening. And
Uh-huh.
if that thing really caves in, you see that thing really cave in, that's where we love these nose cones and the mutes, because that thing sticks up in there like that, and it keeps the side of the nose from caving in. So that is the type of patient guy where we found it has the most profound effect, but it does help keep the nose more open and more patent, which, as if you don't know, it makes a really, really big difference in how well our devices work.
I think it's one of the things you taught me years ago, that pay attention to the nose. I mean, you can use the nasal strips too, the breathe rights. Those can work as well. These, I think, work better. Be aware people's nostrils aren't the same size too. So that's another reason you may have to cut these or put one size on one and one on the other. And I think you just mentioned, I just pulled these out here. This is another brand. If you don't see that, you can just contact us.
You can see it well. Yeah, the Rhinomed mutes.
Yeah, that's another one. What I like about those are they're adjustable, so that if, for someone like me who has one size of nares is a little bit bigger than the other, you can make them adjustable. So the bottom line here is it sounds, if you're sitting there and you haven't done a whole lot of dental sleep, you're going, they're really talking about sticking cones up their noses. Is this really worth my time to be away from the World Series?
It's called the World Series, guy. It's a baseball game.
Baseball game. I couldn't think of the yes. I almost said the Super Bowl, but it is, because this can make the difference between a patient doing not well. They're still snoring. They're still sleepy. They still, if you do a sleep test,
fantastic.
And doing fantastic. This little trick can make the difference. So just like we've said of everything else, have some of them. And if you want to use the mute, you want to use the Max Air nose cones, whichever ones you want. Have some of them. They're $15, $20 a piece. We charge a little bit more than we pay for them just to cover the shipping. And we have them around if someone needs them. We go, here, you want to try these out? This can make a huge difference. I don't think I have a slide on it, but I also mentioned to my patients who have allergies that we recommend that they use some, as long as it's not contraindicated, which in most cases it isn't, is to use some sort of steroid spray. You can use Nasacort now, Flonase, all over the counter. It's not addictive. Like, let's don't confuse that with Afrin. You don't want to be telling patients to use Afrin. That can be really have some negative side effects. But the steroid nasal sprays that are over the counter, I personally use them every night, and in combination with this can make a really big difference. So there's a close up of the nasal cones. And again, Rich showed to cut that off, especially if you're going to use different sizes. I might make sure that you don't cut this part off, though. I don't really love this picture here. That might, someone could get in trouble there with that going somewhere where you don't want it to. So leave enough on the outside that maybe it won't get inhaled up into their sinuses or something. So here's what they would look like. And I tell you what, I swear, Rich, next time I'm running in a 5K or something, I think I'm going to put these in to go running. I feel better when I put them in. I feel in general, even no matter how goofy I might look.
Let us know if your time gets any better. I used them in the last marathon I ran, which was
did you?
When I was 18? But no, I'm kidding. I'm like the guy from Back to the Future guy where he says, run for fun. What kind of fun is that? That doesn't sound like fun to me. But there are other things you can use too. The EPAP, the Provent. Some of this stuff gets a little bit costly. I think this stuff's, $75 a month or something like that. Mm-hmm. You mentioned, Guy, $15, $20 or so is what the nose cones cost, and the mutes. Not too bad. You also have the breathe right strips. So all of these types of things can work, and I think it's good for you to have at least one or two samples of this type of stuff around your office, so that you can encourage patients to do anything and everything they can to increase their nasal pain.
Yeah, and the reason these are disposable, and you can reuse the mute and the nose cones. So these are basically are a little bit different. What they are is they're check valves. They allow air to go in, but they don't allow as much air to go out. And so when the patient breathes out through their nose, it actually causes positive pressure to go back into their airway and keeps the airway open. So it allows inward breathing of the nose and exhale. Now, one trick on these, there's a a physician who does more of these than about anybody in the country here in my area, and he's had fair success with it. But if the patients are mouth breathers and their mouth drops open, well, all that positive pressure just goes back out the mouth. So you might want to do a device that keeps their mouth shut if you're going to be adding these, or if you have one that allows their mouth to open, putting the elastics on in addition to these will make a big difference, because again, if they try to breathe out through their nose, that air goes back down their airway, but it goes out to their mouth, it kind of defeats the purpose. And I've had some success with these. These are more costly because they're about $1 a piece and they're reusable. And I would start with the nose cones because they're less expensive, and these are actually prescription. Body positioning.
Let me add one more thing, Guy. There, we don't have a slide on it, but we didn't talk about the mouth tape. So, you can use that. Some of the other dental educators out there in dental sleep really push the mouth tape. I think it's something you ought to have in your back pocket, so to speak, and take out occasionally and use. I think it's what's the word I want, Guy? It's certainly not the right thing to do the same thing for every single patient. We have to use our brain. We have to figure out what works best for each patient. So if we can get their nose a little more clear, and then we can tape their mouth shut, and it promotes nasal breathing, we might get somebody over the hump. So we'll just
let's explain that quite well. I've had people who just are appalled, I think is the word you're looking for, maybe. Oh, you're going to tell my patient to tape their mouth. But once you understand the goal here is to get them to breathe through their nose, most people do better if they breathe through their nose. So it does work on some people. It's not that we're trying to tell them to be quiet. That's not what we're taping their mouth, or to minimize their snoring through taping their mouth shut. We're hoping to encourage nasal breathing. So I do think some people look at that as kind of a archaic treatment, but in some people it works quite well. I agree as well. And then I think right up there with the nose cones, body positioning, I think, is one of the most underutilized adjunctive treatments in the medical community. I mean, the physicians, someone has an AHI of 30 on their back and 2 on their side, and they're still giving a CPAP instead of saying, here's an alternative for you. And, for us, when someone has an AHI of 50 on their back and 30 or 25 maybe overall, between positional therapy and a dental device, we can take those people who maybe we're only getting down to mild to moderate apnea and get them on down to AHIs less than 5. Yeah, we really can. And there's a lot of different ways you can do this. And don't assume everybody can tolerate this. So what we're talking about here is, getting the patients to not sleep on their back. So, and if we can do that, in a lot of cases, one of the things you want to look at on the sleep test is what is the supine AHI. And so that's how many times they're having an airway obstruction while they're on their back. And hopefully the sleep test will give you that. And if that's, appreciably worse than their overall AHI, then we can look at body position if we don't get the results. I mean, I always start, Rich, I don't know about you, with the dental device and hope I can get them there with just that. But if not, I know if they have a supine dependent apnea to some degree, that I've got this in my back pocket to use.
Yeah, I agree. I agree completely. And I think all of these adjunctive therapies are something that, as a dentist helping to manage a patient who has sleep apnea, I certainly think what we're talking about here is within the scope of what we can do as a dentist.
Yep.
Now, I will tell you, be smart about that. If the guy who referred you these patients is an ENT, and he does a lot of this kind of stuff, or he's been pushing the patient to have their septum straightened and their turbinates reduced or something like that, then encourage the patient to go back and have that done. You need to use your brain, but in general, I will say that I think all of these are certainly within the scope of what we can do as dentists, Guy, don't you?
Absolutely, and I think you need to have some solution right there in your office to give them, so that we don't have to say go. I used to just say go order one of these off the internet. So the
Yeah, how
Parker
many
pillow,
times did that happen, by the way?
like never,
Right.
So the Parker pillows, one in the middle. This one's called the Ramity. These are just pillows that make you sleep on your side. You can tell them to go sew some tennis balls in their shirt. This new Night Shift basically is a sensor with a vibrator. So what it does is, as you sleep on your get in the supine position, it starts vibrating into to the point where you'll eventually roll over. They all work, but we want to have it right there to say, here you go. You want to try this out, and you just have those in stock, and then just pass the cost on along to them. And the last thing I'll add is you want them to wear this for a period of time, because everybody can't get used to this. There's some people that this is just too uncomfortable for them to learn, but if they're doing better with their symptoms, they say, yeah, I'm wearing this every night, no problem, then you need to do another follow-up sleep test with this in place to validate that your results down the with the positional therapy and your dental device therapy. But I could tell you for the patients who have supine dependent or strongly dependent in the supine position for their apnea, if you will know that even at the beginning of the treatment, and I can give that patient a more realistic expectation of success because I know that I have this in my back pocket. All right. Anything else on that, Rich?
No, good stuff. I did think of one thing here too, Guy, which is the chin strap.
Yep. There you go. So
I love some of these pictures. Some of these guys are really creative, in how they do this. So, when might
is that your patient there? Is that the one you're thinking of?
That's exactly what I was thinking of. I didn't know you had that slide in there. So yeah. I mean, look at this guy. You can't make this stuff up, Guy. I mean, this guy really made this.
Yeah. Yeah. So, I mean, instead of the tape, we can use this in some cases. Now, understand, look at the mechanism on this. This can cause the jaw to be retruded. So without a dental device in place, this may not be the greatest idea. But with a dental device in place,
it might cause more problems than it's going to fix.
That's going to fix. So, that's again, keeping their mouth shut. Look, what are we saying here? Look, if you keep the patient's mouth closed mostly, and you get them to breathe through their nose, and you get them to sleep on their side with their dental device, we've just got 3 things here to help our dental devices work a whole lot better. And that's what we're trying to do, because dental devices work well. But there's times where, the AHI is still 9 and the physician's freaking out about it, even though they were started out at 40. And so we want to get them down to that magical number of 5 or below that. Then we add one of these 3 or all 3 of these techniques, and you can really fine tune your dental device therapy. And I still see some questions coming in. We're getting to those.
We're getting to most of those, Guy. That's pretty good. Okay. I do want to add one thing, Guy, and say I like to talk about a lot of these types of things early, like in my consultation. I say, look, success for us is getting the RDI down and getting your oxygen up, you sleeping better, feeling better, snoring less, having more energy, thinking more clearly, all of the things that they list as their chief complaints. And a lot of times, all it takes is a dental device. But sometimes we have to mess with the vertical. Sometimes we have to move your jaw forward. Sometimes we have to, put something in your nose. Sometimes we have to, it's almost always some combination of things. That didn't take that long to say. And it kind of paves the way for somewhere down the road if, in fact, we do have to add some of these other things.
Yeah, because if not, we're kind of making excuses. It sounds like, our device didn't work, so let's try something else. And setting, I think that's key to dental sleep therapy in general, is setting the groundwork at the consultation. We've hammered that in a lot of other previous webinars, and this is certainly part of that. I totally agree. Talk about their nose if they can't breathe through it. Talk about their supine dependent apnea. And not only will it lay the groundwork, they'll be like, wow, no one's even explained all these things to me as well as you have. And it'll increase their confidence in you and your abilities, because you're thinking ahead instead of making excuses down the road. So we're getting through this. There's some other neat things we're going to go through, and we'll answer questions at the end. And again, if people want to know more about what we do, you just type consult in as it says there in the question box, and we'll get the questions that maybe that require a little more time. We'll be happy to meet with you to get to your dental sleep questions, or challenges rather. This Snore Lab app, Rich, and I know there's several other ones out there now. I've been using this one for a little while. Actually, one of our DS3 members pointed this out to me. And I used to use little digital tape recorders, like, the little dictaphones you used to use to, to do dictation. And this is a free app. You can pay for upgrades on it. I'm sure there's other ones out there that are similar now. But having find one and pick one and kind of get used to it. Almost everybody has a smartphone now. And especially for patients who don't have bedtime partners all the time, but still are concerned about snoring. For people whose their bedtime partners sleep in the other room and don't want to sleep in the room with them, we can get some very good information about their snoring in particular from this app. So this one's called Snore Lab. You just you download it. It has some kind of cool features. It allows you to put, if they were wearing any adjunctive therapy like your dental device, if they were using nose cones or things like that, you can put in. You can set the timer to set a little bit later at night. You can put if they were drinking, and they could do this, for many nights in a row too. So it's something you can go and look at and see if there's any trends. Oh, well, that night I slept over at someone else's house, and maybe the allergies were worse or the bed was different. So it's something we can track, and we ask them to bring it in. I don't spend a ton of time on it, but you can tell graphically pretty quickly where people are. And so you can see by just the graphs, and I don't need to get into the whole details of how you read this tonight, but you can click on the higher areas and you can listen. And we do this oftentimes. We recommend that while we're making their device, so we take the impressions, and there's a period of time it takes to get the device back. And if the patient doesn't have a really observing bedtime partner, let's go ahead and start using this while we're making your device, and then we'll have a good baseline to come back to. You can export these files, and the more things you add on, they do charge a very minor amount for, but still it's like $5 or something pretty inexpensive. But the one thing I want to mention that's real important, I'll see if Rich has anything to add, is you want to tell them to put it in the same place, each time. You want to put it, near their bed. You don't want to have a bunch of fans on in the background or the TV on in the background or things like that. So, and you need to have the phone, have the phone plugged in, because if your battery's going to go dead. So, and then if they're going to come back with their device later on, we want them to put it in the same spot, to the same distance from their head and in a similar environment, so we can compare as much apples to apples as possible. Do you have anything on that, Rich?
Well, that's good. There's sure a bunch of them out here, Guy. Somebody asked me to do a talk on that the other day, and about an hour into it, I was like, oh my gosh, I had no idea there were this many out there. There's apps to do everything these days, it seems like, man. And that seems to be, I think Guy picked one of the better ones here that seems to be a little bit more popular. The only thing I would add to that, Guy, is we don't talk about this if the patient doesn't talk about it. So I don't particularly like to deal with these things, but if snoring is their chief complaint,
right,
and it's about to break up their marriage, then let's talk about it and make it a big deal. But I wouldn't offer this for every single patient from the get-go, because you're going to cause more problems than you might otherwise have. Somebody that lives by themselves, nobody's complaining about the snoring. Who cares if they snore a little bit, as long as
I'm with you. I think that goes back to the consultation and being prepared and using our brains a little bit. And what does this patient want out of this? If this patient just wants to feel better in the morning, and they just had a heart attack and they want to lower AHI, then we don't bring this up. Absolutely, 100%. This is for the people who do worry about snoring and have occasional bedtime partners, or their bedtime partner is down the hall because of their snoring.
Right.
And this is something that we put in here, but it's really, as far as I know, we only have this at DS3, but we're so proud of this that I think that this is really a pearl. We spent a lot of time on making DS3 just one of the best dental sleep systems out there. And one of the big challenges are patients come in and we don't know what their insurance coverages are. And in order to find out their coverages, you've got to pick up the phone and call the insurance company. Or if you use a third-party biller, so a company that will do the billing for you, they'll typically charge you $25 to $50 to pick up the phone and find this out. And we have, through DS3, the ability with the click of a button. We have a direct connection. We're the only dental sleep software that has this, a direct connection with over 4,500 billers. So at a click of a button, you can find out if the patient has medical insurance. If so, do they have coverage for the dental device, which is the E0486, yes or no? And if they do have coverage, what is their remaining deductible in and out of network? And also, what percentages are their responsibility, and their insurance will pay the provider in and out of network. So in other words, 30-70 or 80-20. With the click of a button, we can find this out. We don't know the allowable amounts, but we have ways of coming up with estimates if you'll watch some of our past webinars on that. And this, to me, is a pearl that we have at DS3 that has saved me personally, many hours of time and money paying people to get on the phone and find this information out. And if you want to know more how you use it, we can direct you. Just talk to one of our DS3 member support team, and they can direct you to one of the past webinars where we show you how you utilize that feature and come up with the what to tell the patient that their out-of-pocket might be. Anything else on that, Rich?
That's a good answer to have, because I don't know about you, Guy, but I do about 10 consults a day.
Right.
And 9 out of 10 say, "Oh, that's great, Dr. Drake. How much does it cost, and what does my insurance pay? What's my part?" And if you don't have an answer, that's why we put that in there as a pearl. So if you want to do more dental sleep medicine, then you need to know the answer to those questions
at the consultation.
Yeah.
And you can do that with a phone call ahead of time that I have tracked. It takes on average about 40 to 45 minutes to get that information without DS3 to do a verification of benefits and see if pre-authorization is needed and so forth. So it just saves you that time and cost if you're paying a third-party biller to do it. What about implants? I would say, Rich, in our study club meetings, which we have for our members, which are a little more interactive, this comes up quite often, doesn't it? As most cases.
We seem to be scared about it's kind of like the Medicare thing, we seem to be kind of scared about that. And, most of the time, I think use your brain, be smart about it. If you got one implant in the lower, replacing one tooth or something like that, I wouldn't put a lot of pressure on that myself, Guy. I would kind of stay away from it. But, we're getting so much better at putting implants, and with the cone beam and the CBCTs and all this wonderful tools that we have out there now. They're saying we can load these things right away. So I don't think we need to be nearly as scared as we used to be, Guy.
No, and I think just like you said, use your brain. There's a big difference between this case and this case. This case, that's pretty much like any other tooth. You've got a big implant. You've got other teeth beside it that are in good condition. This tooth's can have the same amount of force as the teeth on either side of it. I don't think we have to go crazy about relieving that. Over here, what's the difference? Well, look, we only have 2 little implants. A lot of this is going to be on the tissue. And here we have a fixed that nothing's going on the tissue. And so if you're going to make a dental device for this case, you kind of do it the same as you would anybody else. I would just consider that a tooth. Now, on these cases where they're completely implant born, the question to ask is, does this prosthesis touch the tissue? And if it touches the tissue, and you just take an impression of that prosthesis and make it right to the prosthesis, what very well may happen is that may put different pressure on the ridge in some spot, and now you're going to get a sore spot that's going to be kind of your problem. Now, this case here, there's nothing touching the ridge. I would treat that like teeth, because whether it's fixed or removable, as long as it is totally implant supported, then I just treat them like teeth. So in the case showing up here, this one is a case where if you look at the old tap that we did here, there was a lot of tissue that it was touching. It had quite a few implants, but the prosthesis was actually touching the tissue in many places. So I would rather make it directly to the implant, just like you would an overdenture. That way, if we get sore spots or pressure on these cases, then we've got we can adjust our mandibular advancement device. Here was the lower. You can see we got a lot of tissue that's going to be touching. That we can make our mandibular advancement device is now touching the tissue, and if they get a sore spot or something doesn't feel right, I can go in and adjust my mandibular advancement device, and I don't have to worry about adjusting this prosthesis. The negative, the flip side to that is that it costs more money and time to do it this way. You've got to, buy all the parts. You've got to do a lot of the same work that you would do if you were restoring that case, and it can take a lot more of your time. I guess one other added benefit is you can make this at a slower vertical if that's desired. Sometimes when you make them over the implants, you end up with something that's a pretty high vertical by the time after they've restored those implants, especially if the ridge was pretty high and they didn't lower it down when they put the implants in. So again, to reiterate, if it's a tooth, it looks good, treat it like a tooth. If there's tissue associated with the prosthesis, consider making it to the implants themselves. And if it's totally implant supported and all the implants look secure, then treat those like teeth. Anything else on that, Rich, that I missed?
That's very good.
Yeah.
I don't get to do a lot of that, Guy. I'm very limited, and I don't know why. Maybe I'm not looking for it. Maybe I'm not doing general dentistry, so these aren't my patients now. But that's a wonderful service to have. I can tell you that we have taken completely edentulous patients, and we've got them to dentists to put implants in. So yeah, we and we're going to talk about somebody that doesn't have any teeth on the top, but if people don't have the means to go get several implants done, and I think that costs quite a bit of money these days. If they have the means, then as Ferris Bueller says, I highly recommend it. But after he drove that Ferrari in the movie there, so that's one of my favorite lines in the movie. But
yeah, don't be afraid of the cases. Use your brains. If the implants are weak, then we've got to be careful. But if the implants are big, well osseointegrated, mini implants, we feel good about the durability of it, then go ahead and make him. And you can make them right to the prosthesis even if they touch the tissue, but you might end up getting yourself in trouble. So I see more of this than you did. I did a lot of this in my general practice for many years. I did a lot of implants, and in Florida we just see more of that. And I don't say we do a ton of it, but I see people at least weekly who have implants, and I probably treat them monthly who have at least one arch or more of complete implants down here in Florida. So it's not something that scares us. The only other thing I would add would be if you're going to make it right over the prosthesis, and it's an implant-borne prosthesis, sometimes these acrylic prostheses don't have good undercuts in them because they're acrylic teeth or denture teeth, and sometimes you may have to add some undercuts in the prosthesis to get your dental device to go over them. And I prefer the flex material many times when we go right over the prosthesis, but typically I only do that when it's totally supported by the implants. And this is a technique here, Rich, that I think because I have done a lot of dentures and prosthesis over the years, I pretty much figured this one out on my own. And we had a lot of patients here in Florida who do have upper end dentures. A lot of people spend the money on the implants on the lower because lower dentures don't do real well, but they're doing fine with their upper dentures, so they don't spend the money up there. And you might try this on the lower, but you've got to have a little more patience and luck than I do with that one. But for the completely upper edentulous patient, if you're willing to take the time, this technique will work quite well for you. I will mention for this and for the technique we just talked about with implants, making right to the implants, you're going to have to charge the patient a little bit more. It's going to take you a little more time, and you're going to have a higher lab bill. But when it comes to this, some of the training I had when I used to do a lot of dentures for nursing homes, this little denture duplicator was my friend. And I think this is what made this all possible. If you don't know what this is, it's just a inexpensive piece of equipment you can buy from your dental supply company, and you can duplicate a denture with it. You just add alginate in one side, pretty like 3 scoops, mix it up, pour it in there and vibrate it, and then sink the denture in it. And then you want to put some separating medium. We use this expensive separating medium called Vaseline, and just rub it all on the alginate in particular, and you can get it on the ridge of, get it on the denture as well. And then mix up the other side full of alginate, and then squeeze the whole thing together. It's got a little screw on here you tighten down. One of the questions that always comes up, Rich, which amazes me, is, well, can you use like polyvinyl siloxane or one of these other impression materials in there? Yeah. You know what the answer to that is?
Yeah, if you got a whole bunch of money, sure.
Yeah, if you got more money than sense, then yeah, go ahead and use the nicer impression material, because that'll cost you about $300. But alginate works fine. You'll get a few voids, as you can see here in this, but nothing that you can't deal with. And I just wouldn't waste the money on the more expensive material by doing this. So once that sets, the alginate, you just take it apart and you have a mold of your denture. Maybe you already know how to do this, but if you don't, there's what you have. And then I just use a clear ortho acrylic, make it kind of liquidy, and you got to mix up a bunch of this stuff. So you need your bigger rubber bowl, not that little bitty one you use for crown and bridge. Mix that up, vibrate it down into one side of the mold, and vibrate it into the other side as well. And then you want to tighten that screw back down. And all the extra acrylic will squish out. Now, real important, the alginate is not that big a deal because it's flexible, but you want to remove all this extra here before it hardens. Ask me why I know that that's important, Rich. Because I'm like you, we've learned a lot of mistakes there. I got around this one time and locked on, and it took me about 15 minutes of cutting all that acrylic off to be able to reopen this thing out. So do yourself a favor, while it's soft there, go ahead and just trim off that extra. And then once it's hard, you just open it up, and you're going to get something that looks like this. Yeah, you just got to smooth it up a little bit, get rid of that flange. Now, if you know how to reline a denture, this is real remedial. You just go in and you remove the undercuts. The reason you do that, if you don't, the model will break when they pour it up and they try to pull it off the model. That undercut will catch, and it'll crack the model. So go ahead and remove any major undercuts. And then we got a duplicate of the denture. Now, typically these dentures are old; they may not fit perfectly, so I'm just going to go ahead and reline the denture, the acrylic denture, so I can see it's overextended up in the buccal flange here. And you didn't know you were going to get a denture course today, right? We removed that back to where we had enough room for the material, put a couple holes in it, put your your adhesive on this, and then we reline it. And you border mold just like you would with a upper denture. You have the patient just bite down into that, even though it's not that critical where they bite, and then you trim it up, and this is what you have. Again, if you have a good team member, they can certainly duplicate this denture for you. You don't have to do that yourself. They can do most of this. I prefer to reline it myself. And now we basically have a temporary, a relined duplicate denture, and we'll put that in and just take your bite like you normally would. You send all that to the lab, and there's really only a handful of labs that do this well. We don't try to name drop labs too much, but I'll tell you, SomnoMed's probably my favorite for this. They do this real well, and they can do a Herbst or a dorsal very nicely. And so they'll make it right to the ridge. Now, you see this does have the hooks for elastics, and if you've got really good retention, you might be able to use those. If the patient doesn't have a real good ridge, you won't be able to. And these usually fit well. What I like about this, as opposed to making it over the denture, is that it's less bulky. And where is this going to get a sore spot? It's going to get a sore spot, if anywhere, right here in the buccal flange, as that's pulling back on the upper. And that's also where the retention comes from. And if that's on the denture and I have to adjust this denture, now the denture may not fit. And I don't want that. I would rather make my adjustments on this, on my mandibular advancement device, and leave that well-fitting denture alone. And this technique, I probably do 2 or 3 of these a year at least. And it really is fairly predictable. You've got to add a little bit more because it's going to take you a little more time to do it. And the last subject, Rich is the expert.
How much time, Guy, do you think? I mean, we have a 2-hour appointment when a patient comes in for that.
Yeah, and that's about right, but that's not all doctor time. It takes about 45 minutes to an hour to duplicate that denture.
Right.
And that's something, once you show a team member once, they should be able to do. So
Right.
that shouldn't be your time. They should be able to duplicate that denture within about an hour, trim it all up. And then you're going to go in and, make your adjustments. If you need to bore your mold or what have you, like you used to for a reline, that usually takes, 10, 15 minutes. And then, a normal impression appointment takes a half hour to 45 minutes anyway. So you're talking about maybe an hour and 15 minutes longer to do this. And the lab bill is going to be a few $100s more. So whatever your time's worth or your team members' time's worth, mostly to add more. We used to add like 1,500 more for these, but we've gotten it so much more efficient. We don't add that much more than that now. It's probably about half that we add to what we need to do one of these. And the deliveries usually go pretty well. I don't have to adjust them that much anymore. It seems like we put them in and they do quite well. So Rich talked to us about combination therapy, because I think I'm a little bit more the expert on those dentures, because I've done over 1,000 dentures in my dentistry career. But I haven't done 1,000 of these, and you've done a lot more of these than most people.
Yeah, so sometimes CPAP works, sometimes it doesn't. Sometimes our dental devices work, sometimes they don't. So we have to remember that number one, CPAP is not our enemy. CPAP is our friend. I don't think it's an us versus them, which a lot of people preach out there. I'm not one of those people doing that. So, when we have a patient where CPAP doesn't work as well, or they have a difficulty with one or more aspects of the CPAP treatment. And, we do this guy on a lot of patients. When they come in, they have AHI. For those of you getting started, that's the apnea-hypopnea index. That's a measure of how many times they quit breathing per hour. So anything over 30 is considered per hour is considered severe sleep apnea. I mean, we got guy with 110, 120, 125. We had a guy the other day, his LSAT, the lowest saturation his oxygen went was 39%. It's like, oh my gosh. So, we're going to combine these therapies where we do both. So we have a couple of options for how we can do that. You can order these from Airway Management. It's called the TAP-PAP, okay, nasal pillow. So it is basically the top part of a MyTap, which is their temporary device. On the right there, you see that where it's got the nasal pillows on it there, and they come in small, medium, and large. And then the dental part of that goes against their upper teeth is thermocryl. So we get it real hot. We put it over their top teeth. We kind of mold it around the edges, and then we have them bite into it real hard. And we tell them to suck like they're sucking spit back through their teeth. They're making that kind of sound, and they're doing that. So you suck that maxillary. It's just a single device there.
Right.
There's a screw on the side that you adjust the angle that comes out with. And then you just take small, medium, or large. That one fits about right. And that hose is a universal adapter that will plug into any CPAP machine out there. Now we can get lip closure because we're not having a lot of vertical here, and the nasal pillows go in.
Right. And this makes a much more stable connection. It's not going to be moving around. And I want to mention that Airway Management picked a real stereotypical apneic patient here for their for their marketing. But I think the advantage there, what we want to emphasize is one of the biggest problems people have with CPAP is that the mask moves. They move over in it. It gets an air leak, and because the straps are having to be pulled tighter, and this makes this whole contraption a whole lot more stable because it's attaching to the teeth. And I think there's some more close-ups, and that's the same kind of material. It's a little harder material as well. So, I mean, one of the goals is to make a more firm attachment so it doesn't move around. And then the other goal, Rich, is to move the jaw forward and at the same time make that firm attachment when you do these custom masks, right?
Yes. So just to be clear, we're talking about two different things here. They're both combination therapy. One, I believe that the TAP-PAP you buy for about $150 from Airway Management. So go back one slide, Guy. There, that's the TAP-PAP chair side. Okay, we charge about $600-700 to do this. It takes about 15-20 minutes. You know who is our number one patient that we make this on, Guy? Consistently. It's a younger female, and you know why we do it? Because she doesn't like the marks that the straps from the CPAP leave on her face. It's like they don't go away until like noon. You know, I had a coworker the other day say, "Oh my gosh, you wear CPAP too? You know, how embarrassing is that?" Because of the straps on my
That makes
face.
sense. Yeah.
So now we're going to graduate. Okay, now we're going to actually take an impression of somebody's face. Okay, and we're going to you get this kit from airway management as well. There's little breathing tubes in there. So we're going to assume that this patient already has a tap that you've made them. Okay, then we're going to heat up that thing. It's a thermocryl Kevlar type of mesh. So this guy Kirk, he has the tap device in his mouth. We take the outside 2 screws, and that centerpiece is a post that comes with the kit, and it has a little breathing tube things that come on the side. It's very important that you keep those clear, guys.
I can see that part. That's
because you actually take cotton rolls and you put them way up their nose. It's kind of weird to do that. And then you squirt the PVS into their nose. You know, you want at least 6 or 7 millimeters of the inside of their nose. So we're basically, this is our custom tray to take an impression of the face.
right. That's
So
really
what we
cool.
do, yeah, and now we can take that dental device. You can see on the left there, we've taken that impression of that guy's face, and we've now made a custom mask, and we have a mechanism for how we hook that little post and bar system in there. So now we've got a tap, and we basically slide the custom mask over that blue hole there that has little set screws on the side, and
Right.
then we snug that mask up just right, and then we tighten the little screws down on the side, and that hose is a universal hose that fits to that. So this
Yeah.
guy, go ahead.
Also, we want to emphasize. I'm not. Most of what we've shown, I think you can go back and do tomorrow if you want. From what we've gone over here today, I think this is a technique that you'd. I don't think airway
Don't
management.
make this your first case, guys.
Yeah, right. That you need to go to one of their courses. They teach you how to do this. I think even before they'll sell you some of the equipment. But we want to make sure you're aware of what a valuable treatment it can be. Because now look at this guy. I mean, he's got a fixed advancement. His jaw's more open. He's got a really custom-made mask that doesn't leak and
Does not leak.
does not leak.
It
And
does not move when he rolls over.
And the studies, there's a study what Dr. Prain did, I think, that showed about 20 patients or so that they went from totally unsatisfied, most of them, to mostly satisfied because the leaks and everything were alleviated there. So, I think it's something that if you're looking to expand your dental sleep practice, starting with something like this, and talking to your physicians about how you can help some of their patients better tolerate CPAP, you can do this tomorrow if you've had just a little bit of experience in dental sleep. And does that help your patient your referrals from the physicians, Rich, when you do these type cases?
Oh, man, you better believe it. A lot of times that's the key to getting more referrals.
Well, I think we've gone through some pearls. I promise you some of these things will make you more successful. It will make your life better as far as predictability. It'll make your patients' lives better. We feel that if you are taking hours and hours to do this, that you don't have the proper systems. I used to take hours doing this, and once we put DS3 together and we have ways to do all the steps of dental sleep, this should take less than an hour of the doctor's time on average, and we should be able to do it efficiently and to the patient's satisfaction as well. There's no reason not to get involved in dental sleep. I mean, it's enjoyable. You're helping your patients, and there's nothing you can do in dentistry that can add more to your income. I mean, if you're doing a device a month, 12 a year, you're adding almost 20,000 to your net income, not just your gross, because we've accounted for the cost of the devices in this. We've added the cost of even having third-party insurance billing in it. This takes very little of the dentist's time, and we know practices that were struggling and now doing quite well because they've added dental sleep to their practice. we as at DS3, to reiterate what we do is we help dentists do these things. We help everything from help you learn how to screen, how to test, how to bill, and how to treat your patients. If you have more questions about this and you just are challenged and you think, gosh, I'd like to learn more about dental sleep, then just type in free consultation. Just ask us to give you a call. We'll set up a time to where we can better understand what your challenges are. I promise you that we can help you through the challenges on what we do here. The big challenge for Medicare next next webinar in 2 weeks, we'll talk more in detail about this than I think we ever have, Rich, on Medicare patients and how you get your Medicare status, what the Medicare statuses mean, to how do you collect money and get paid for it.
A lot of good stuff, man. We got a couple of really nice webinars coming up. If you're not a subscriber to the Dental Sleep Insider, it's free. It's a digital online magazine. It's very cool. Very lots of great practical information in that. It's easy to do. You just go to the link there and sign up. I'm just kind of looking through the questions, Guy.
Okay.
I think we've got most of them there.
I'll look at them here as well. Again, if you wonder what we do, we help with the education, coaching, software, and support. So just check out what we do. If you're interested, again, let us know. Type in consult, as we mentioned. I'm going to put our contact information up here next. There you go. And let's see what kind of questions, anything that we haven't gotten to here, Rich. Look here. No,
I just checked my phone. The World Series is tied up 1-1 in the fourth inning. For those of you anxious to get, spoiler alert, I guess there for those of you who did TiVo it.
Okay.
No, I think we got most of them there, Guy. Thank you for putting that PowerPoint together. That was good stuff. And 2 more weeks? When is our Medicare one? Is that 2 weeks from tonight?
2 weeks from tonight. Yeah, I'll go back to the slide to make sure I got the date right. November 7th. So make sure if you like this, we'll have some hopefully we deliver some great information. We're very practical in what we do. I think we're the only company out there that really, our whole focus is on making this easier for dentists, because we know that it's challenging. We're both dentists, and we've put this, Rich and I founded this company on a napkin one day when we decided we were just tired of dentists not being able to succeed at this, and we decided we were going to try to do something to make this better for practices and more easily implemented. And I think we've done a lot, and we're continuing to do a lot. Medicare has come a long way. We started this, Medicare didn't pay anything on these. It wasn't until 8 years ago or so, Rich, that Medicare even started covering these, maybe 10?
Yeah, and everything is a two-edged sword. So, why you guys in the Northeast get twice as much money as we do here in Texas and Florida is unfair. We want to revolt, but don't let Medicare scare you away. A couple weeks, join us. We're going to break it down into very step-by-step, very simple things, and we'll go, hey, A, B, C, D, E, this is what you need. This is how you do it. And you'll be ready to go, man. I mean, it doesn't take long. And again, this gets back to helping people, feeling good about what you do. The work is rewarding, so we encourage dentists all day, every day through the DS3 experience to help more patients and to do this better.
Yeah, and there's how you get a hold of us. You want more questions, that upcoming webinar, you will get credit, an hour CE for it, and someone will be in contact with you if you need the CE for this one. And if you have any other questions, just email info@dentalsleepsolutions.com, and we'll get right back to answering any of your dental sleep questions about this particular webinar or anything else dental sleep related, because that's, again, all we do. So thanks for taking your time, everyone, and we appreciate it. And I guess that if we've answered all the questions, Rich, I'm going to sign off the go to webinar here.
All right, guys. Have a good evening. Thanks again.
Thanks. All right.